we are very pleased to introduce our next speaker, Ben Sims. Ben has been the CEO of the Tropical Health and Education Trust since 2015. He has 30 years of experience of working internationally with an emphasis on global health and disability work. He has worked extensively across Africa, Europe, Latin America, and Asia during this time. He's been using the opportunity to harness expertise from across the UK health community in the NHS and in specialist medical charities such as Sue Ryder and Sense to benefit the development of health and social care in low and middle income countries. For the last 15 years, he's been in leadership roles, building a strong track record of advocacy and programme innovation and working closely with the UK government and UN agencies. And we're very pleased that he has kindly joined us here today to talk about some essential advocacy work that he, FET, and other organisations have been focusing on in recent years. Thank you, Ben.
Sonia, thank you so much. I'm blushing slightly, but it's very lovely to be here. I am a huge admirer of you and of the Zambia Anesthesia Development Programme. So it's fantastic to be showing solidarity by joining you today. And I was able to join a bit earlier, and I'm really, truly impressed with the conference that I'm seeing. So I'm hoping you can see my slides and you can see something of me in a corner somewhere. I can't, which is a blessed relief. I feel as if I have to make some, caveats before I start speaking. The first is that I sort of see advocacy as an act of optimism. It's not an art. It's not a science. It's more of an art. It's a very necessary one, as I hope this presentation will help demonstrate. But there are no strict or clear rules about how to set about it. The second thing I want to say is that advocacy is very context specific. I'm sitting in West London looking at the appalling weather out the window. And this presentation is inevitably quite UK centric. It's full of the confidence, if you like, some of it questionable, of living and campaigning in a democracy, with the caveat that we're living in a democracy which is having a nervous breakdown and introducing some pretty punitive legislation, which is currently threatening our ability to speak out freely. But some of these assumptions about democracy and the right to protest will inevitably influence the way I'm speaking. So remembering those things, please, pick and choose, take or leave anything I have to say. I'm going to focus on FET really and the work we do with Sonia, with the Zambia Anesthesia Development Programme, with the health partnership community, apart from anything else because of limited time. But I'll draw on wider experience. Do you know, I was trying to add it up, but my first demo was now over 40 years ago, which is just a remarkable thought. And it's been my privilege to be associated with two major social revolutions of the past 30 or so years. One being the fight to ensure recognition of the rights of disabled people, and the other, the fight for equitable access to antiretroviral drugs across the world. Most notably in my role as Chief Executive of Stop AIDS, a campaigning network based in the UK. I should say, by the way, that advocacy is not FET's first love. Our first love is supporting health workers, is training, educating health workers, is the flow of expertise that improves the quality of healthcare and outcomes for patients. But in this presentation, you'll see that I'm focusing on the advocacy. And in this slide, I refer to that term, the health partnership community or movement. Soon after I joined in 2015, Lord Crisp invited us to think of ourselves as a movement. And what he was thinking about were the themes of equity, of equal collaboration, of bi-directional learning, the themes that really matter to Lord Crisp, and which matter to THET and the wider health partnership community. So from that UK-centric outlook, I'm going to ask basically 3 questions. Why do we think change happens? How does it happen? And who makes it happen? And reflecting on the first question, you know, we often talk about lived experience. So the lived experience of politicians. Our Prime Minister David Cameron had a disabled son. Our Prime Minister Gordon Brown had a visual impairment. We often take as our starting point, you know, what is it that sort of motivates the individual politician? Where are their interests? And we sometimes talk about personal relationships, don't we? Who knows who, and how can we get messages, channel messages through in order to persuade a decision maker to make a certain decision. But I want to take my starting point, I think, in answering this question, why does change happen, with this quote. And I'm racing to open up the chat box because my question to you is, who do you think said this? Not the name, but where do you think the person lived? And when, in what year do you think they said this? And I'd be very grateful if I could see some guesses on the chat. If I don't see any guesses, I'll be upset and convinced that I'm just speaking to myself. Way out of date. Yes. High income. Yeah, 1990s. Great. High income. Correct. Way out of date. Yeah, but what way out of date? Recently, yes. Yeah. So for me, so I'll put you out of your misery, and maybe some of you have seen this before, but it was in fact 2001, which for me feels very, very recent. It feels like yesterday, 2001. Certainly it's this century, not last century. And it was a key member of the Bush administration. So part of President Bush's team, a certain Mr. Natsios. And I find this staggering. So the person who said that perhaps that kind of outlook, that attitude lingers today, I think is probably right. But can you imagine, we were heading past 20 million people who died of living with HIV, died of AIDS. We were moving towards, I think the total has become 34 million people have died of AIDS. And yet we had that kind of statement justifying why treatment shouldn't be rolled out. And it was Peter Piot, who I love very much, and his autobiography, which is No Time to Lose. I don't know whether you've read that, but in that, Peter Piot was the first chief exec of UNAIDS, so started the role in 1994. But in that, he makes this observation. I'd begun to learn that in international politics, there are only 2 things that count, the economy and security. As they say in France, the rest is just literature. And what he was referring to was the fact that AIDS got onto the agenda. It was the first health issue to get onto the agenda of the Security Council. Why? Because soldiers were dying and because economies were in jeopardy. So it was the economy and security that got those politicians to make a decision about HIV and AIDS. And I think it's sort of interesting reflecting on the fact that we are still in a pandemic and just contrasting the response to AIDS, to HIV, with what's happened with COVID. because the scale of challenges, the reasons why we might engage in advocacy are just enormous at the moment, aren't they? I particularly want to pay tribute to Sonia, who spoke at our THEC conference, in fact, on the theme of vaccine inequality last year. So we've seen this hugely challenging time. And this is why we get out of bed in the mornings, and this is why we do advocacy in 2021, 20 years after the example I was talking about. So how does change happen? Here I'm just going to linger on that Nyakan concept of inner and outsider advocacy, which I'm sure many of you are familiar with, but which I find very helpful. Because I do think that at FET we have to kind of prioritize our energies. We can't do everything. We can't influence, you know, everything. So we always ask ourselves, what is the value added we can bring when doing advocacy? For the most part, we're an insider advocacy organization, but I did want to highlight two occasions over the last year where we've gone public. The first was this devastating cut to UK aid when the government last April decided to reduce UK aid commitments from 0.7 to 0.5. And we went public there, and perhaps the high point of that was the headline on Channel 4 News, where Victoria MacDonald, the health correspondent, did this report, UK aid cuts at worst moment in the middle of a pandemic. So we went public on that occasion. We didn't change the outcome, but we nevertheless registered our view, which felt important. And then the second was last Tuesday, this Tuesday, so 3 days ago. And I'm, to be honest, feeling still quite emotional about this, where we stood in Parliament Square in solidarity with the Myanmar diaspora here in the UK, protesting the impact of the coup, during which at least 20 health workers have died, over 280 have been arrested and subject to violence. And we've seen devastation of health services as well as health institutions. So on Tuesday, it just felt appropriate to go public, and we did it through the protest in the square, but also the wonderful solidarity of the UK medical royal colleges who lit up their buildings in solidarity. It was very moving. But as I say, for the most part, focusing our energies, that is takes an insider influencing approach. So here are some of the papers, and from competition to collaboration is very much about international recruitment. It was written thanks to our work with Health Education England. It led to a whole load of work which is captured from Drain to Gain, which involved the Minister of Health from Sudan, Lord Bethel, a DHSC minister, Jim Campbell from the World Health Organization. So we had a series of really good questions, challenging ourselves to ask, how acceptable is it that the UK recruits so actively from abroad in order to reach its staffing targets, and B, accepting that people have the right to migrate and improve their lives. How can we manage that in a way that doesn't have a devastating impact on the low middle income countries from which they're coming? So we tend to use the insider approach by convening, sensible people with excellent knowledge and having discussions and exploring these themes in a way that is useful and constructive, we hope, for decision makers. And this kind of shows the spectrum that we're trying to move from evidence to influence. So we do that both by understanding our own program work, the work that others across the health partnership community do, and also by seeing ourselves in context. So not just sort of learning from what we're doing through training and education work, but looking at that work in context like migration of many people who train away from the countries in which we're training them. So the third bit I wanted to just linger on, which I hope is useful, is who makes change happen. And I think that's a really important part of the equation. I mentioned to you that I've had the privilege of working in solidarity with disabled people and people living with HIV. And those have been some of the high points of my life spent professionally in allyship. And who makes change happen for me, first and foremost, is people with lived experience. And I think that, you know, when we protested the aid cuts, we were particularly enjoying the respect that health workers themselves have. Your voices are highly regarded and considered to be highly authoritative. So you can see how we lingered on platforming the voices of health workers themselves, because it is your lived experience, which I think is very valid. And to that, recently, we've added this additional sense, this additional awareness around the diaspora. So in 2019, we looked at reverse innovation. We asked ourselves, how can the NHS learn more from low middle income countries? And we realized that one of the ways to do that was to send people overseas, British people overseas, to study health systems. But what we then realized is that we have experts in our midst. 1 in 7 of the NHS staff are born overseas. And we don't do enough to listen to their expertise, to collate their expertise, to understand their views and what they bring to the table in terms of learning from other health systems and innovating in the delivery of our own health system. And in 2019, when we did that inquiry, we were very alive to unconscious bias. A wonderful academic called Matt Harris from Imperial guided our discussions, as did Lord Crisp, who wrote that wonderful book, Turning the World Upside Down, as I'm sure many of you know. But it was that recognition of unconscious bias, which in 2020 became a much more confident recognition of racism and how racism is impeding our ability to value and see the expertise residing in the experts in our midst when it comes to global health. And so when I look forward to how we're prioritizing our work this year, it's very much at the moment with the lived experience of NHS diaspora staff foremost in our ambitions. So I've tried to sort of talk about why does change happen, how does it happen, who makes it happen. I gave you the caveats right at the beginning, because every context is different, and this is by no means an exhaustive exploration. But as I look to the future, I would like to acknowledge that, you know, I talked about the climate in the UK, and the police crime sentencing and court bill is the one I was referring to at the beginning of the presentation. It's very, very worrying to see the UK government's appetite to close down spaces for freedom of speech and the right to demonstrate. But I'd like to end by saying, you know, any of you who would like to get involved in our work, it would be very welcome. We've got what we call a Health Advocates Network, which you can find on our website, where you can volunteer to become an advocate, part of our network, and we will then work with you to find spaces and opportunities to get in front of decision makers to influence the way they think. And this was an Ipsos Mori, which I'd be very, very grateful if people didn't circulate on social media or anywhere else. But we did an Ipsos Mori poll, the largest one ever conducted, can you believe it, harvesting attitudes towards global health across the NHS workforce. And you see this huge, I think this is huge, this huge interest in speaking up for the things that NHS staff think are important. And it was a very welcome series of findings, which we'll try and make something of a splash of later in the year. Hence, I'm asking you not to circulate it at the moment. So, Sonia, I'm very grateful for the invitation. I hope that was interesting. It gives you some sense of the way we approach advocacy within FET. And I'm still here and happy to answer questions.
Thank you very much, Ben. That was really interesting. I have a few questions myself, and I think that there will be some coming in the chat already. I'm hearing from lots of people that they've really enjoyed your talk so far. I think that COVID-19 has been a perfect example of how learning is a global venture and how we have all benefited from shared learning. In the UK, we had our first COVID-19 cases a lot earlier than some countries, but we still learned a lot from those ahead of the curve in us. But at the same time, we have learned an awful lot from other countries who have used incredible innovation. And I really turn to our Zambian partners during that, because some of the ways that they have managed to keep patients who would otherwise need to go on a ventilator off of a ventilator and improve their outcome has been truly, truly phenomenal, and ideas I would never have thought of. But how can we, as the health partnership community, really show leaders in the NHS and our government in the UK and other high-income nations that we really must put health partnerships centre stage and realise how much high-income nations benefit equally as well?
Yes, and I'd love to achieve that, because at the same time, the COVID experience has been a moment of national humility, hasn't it? Mm. So we didn't learn from other countries. We saw, for example, what was happening in Italy and didn't learn. So it's important, it's a good moment, that moment of humility where we perhaps can sort of think about how, if we were better at learning from other health systems, would we actually get better outcomes for our population? And throw into that the insights we've got into how inequality has impacted people, our population in the UK's experience of COVID, then of course we've got a wonderful platform of rich insight that can help us think differently and change the way we do things. So my obsession is, I just really enjoyed what you just said. My obsession, I think, is we need to document this, and if it was possible, it would be so lovely to produce some kind of report, some kind of document capturing those innovations, those examples, but very much through that lens of, yes, let's be proud of the NHS. And I'm the first to be guilty of kind of wearing it as a slogan across my chest. The first, universal health system, 1948, free at the point of use, etc. Let's be proud of it, but let's be proud of it because of our ability to be humble, because of our ability to learn from others and the experts in our midst, not just because we think, oh, we've got the best health system, which clearly we haven't.
Absolutely. Thank you very much. I've got a couple of questions appearing in the chat. The first one says, hi, Ben, don't you think that the systems, health systems, economic systems and political systems in the world are intentionally and actively made in such a manner that the status quo of LMICs should remain so for the benefit of a few high-income nations? This includes the health sector in all forms.
Yes, and I think that we're in a very brilliant moment transition in terms of thinking what international development is about as well. And at the core of that is recognizing that flows of aid are relatively minor influences in terms of global inequality, and why low middle income countries are less well off than high income countries. And other factors such as tax evasion, tariffs, these are the things that shape the context in which we work. And I do think it's important that we have an eye to those systemic issues, which are much bigger than international aid or international development, and our pleasure in exchanging learning and training, educating each other. We should have an eye to that and recognize the truth of what Ninza's saying in that question.
Mm.
And I think that it does play out in obvious ways in health systems, doesn't it? I've banged on about international recruitment because at the moment I'm slightly obsessed about it. I think one of the worrying, when we see the Kenyan president saying he's got unemployed nurses in Kenya and sort of thrusting them into the arms of the UK health system, it's a very worrying distortion of what is actually needed for Kenya, which is the absorption of greater numbers of nurses into the Kenyan health system rather than, offering up them for recruitment in high-income countries. And I do think that that kind of migration on that kind of scale does risk consolidating the inequity around, low and high-income country health systems.
Mm. That links in possibly with what Sompwe was saying after the SARS update earlier on about how efforts within Zambia to try and develop human resources, care for health workers in terms of regular pay, she was saying, annual leave and other things as well, might be a very big part of that too.
Mm.
We've got some questions popping up about UK aid as well. This is a topic very close to our hearts as a charity as well. As you know, Ben, that we had a UK aid grant cut 4 months into a 12-month project, which has really affected us. And the question here is, how have you adapted and assisted with those with reduced project funding due to these cuts?
Yes. So in some ways, the answer is, of course, we haven't. Like you, we lost 2 UK aid grants, and we lost our main program, which was a year. We were a year and 4 months into that program, which was the health partnership program. So the total amount we lost was 48 million. And I say we because partly it was about THET, mostly it was about grants that would flow to the UK health community and partners in low middle income countries. It was devastating. The same week we got that information, I had to do that seminar with Lord Bethell, the government minister, and all I felt like doing was going on strike, to be frank. I sort of wanted to walk away and disassociate myself from the government because it was just so painful. So we cannot replace that loss of funding for our partners such as yourselves. There's no way around it. We've picked up some other grants. We're doing really interesting work with Department of Health and Social Care, particularly in relation to antimicrobial stewardship, which I'm very proud about because I think that as we grapple to learn the lessons of COVID pandemic, having not learned, by the way, the lessons of the HIV pandemic, which is, one of the kind of connections I think we can make. Looking at antimicrobial stewardship, we clearly have a similar global challenge which affects us all, and are we really taking that seriously? And then in terms of THET, I mean, if you're asking about THET, it's just a bizarre thing to work for an NGO. I can't tell you. On the one hand, we lots of freedom, lots of fun. We are allowed to kind of, we have quick conversations and then deep thoughts, and so we have agility. But we also have zero employment security. So it's a nightmare, and often I think in very different ways, because what you have been through as health workers is obviously very different, but in very different ways, we too are exhausted and struggling with those things that keep us resilient in order to, come out in solidarity with health workers. For example, like we did this week.
Absolutely. I think in whichever context you support health and global health, resilience is something that has been affected in us all, and there are most definitely very emotional aspects to the loss of UK aid, as I think you mentioned and others will mention today. It really has been a double blow with COVID-19 and the loss of funding that is there to support other vital areas of healthcare work. We've got another question here in the chat for you. How do we pull together all healthcare charitable organisations within the UK and abroad, as the overlap can be incredibly inefficient and duplicative?
Yes, thank you for that. On advocacy, we're better at it. So we're members of Action for Global Health, which is a rather wonderful UK network, about 50 organisations making common cause, strategizing in common in order to maximize our influence over the UK government. And we're also, in advocacy terms, we're members of international networks, which also raise their voice on behalf of health workers. So advocacy is better. On the joining up of charitable organizations programmatically, I always have I have a first thought, which is it's not our job. It's the Ministry of Health job. I would not presume to take that role on. What I think is every organization should be coordinating with the Ministry of Health and supporting their efforts to provide the leadership that gets us coordinated in any country that we're seeking to work. But I do think there are a few other initiatives that could help. Noticeably, the UK health alliances. Very much to my regret, the one in Zambia has become less active, but there are colleagues beavering away effectively in Uganda, Myanmar, and we've seen recent alliances developing in Kenya and Nigeria. And I do think those alliances at their best can be great mechanisms for coordination, at least across the UK health community, as we think about contributing to the development of the health services in those countries. So I think there are ways of improving coordination, but I salute those in the ministries of health who are at the forefront and provide the leadership that we ultimately should be deferring to.
Well, thank you very much, Ben, and thank you again for coming to talk to us about this today. I feel like this is a topic that we could easily spend the rest of the day on. And again, we will gather any more questions for you and send them your way if you wouldn't mind responding to those. Thank you again for your time.
I'd love to, and do join the Health Advocates Network if you feel like you do, Sonia, that you want to lend your voice. We would appreciate it. Thank you so much for inviting me.
Thank you again.